So, good morning and welcome to this narration, which is basically um, an orientation about the integrated disease screening and management that we're piloting in some centers, some facilities in River State. So, I'm quickly going to take you through some of the protocols, the size, benefits, how we intend to manage this new paradigm in terms of getting the system to be strengthened, opening access and making recovery from pandemic faster and reliable. My name is Goldin. I work for River State Ministry of Health, and we we're actually piloting this process of system strengthening and recovery from the pandemic by expanding services. I actually provide the technical lead for incident command systems within the state. So, like I said earlier, the major aim of this orientation, which is going to be a bit brief, is going to show you how we intend to mainstream this integrated disease screening and management. I'm going to show you the sites, tell you about the considerations that we intend to make, and also show you the protocols and models and how it works. To begin with, the idea is actually to screen all offer screening services to patients who come to facilities for COVID, HIV, and TB. And this is because these diseases actually occupy important place, and they are categorized as priority diseases in terms of control interventions in the public health space. So we're going to talk briefly on how this can be possible. For COVID, you all realize that it's a pandemic. For HIV, you know that Nigeria and South Africa actually bear the greatest burden of HIV in the world. And of course, for TB, Nigeria is also rated basically number 3 in terms of the burden of TB around the world. So this calls for concern and recognizing the fact that now that we're dealing with both pandemics, ordinarily called syndemic, or COVID and TB, or COVID and HIV, and remembering, of course, the fact that we have vaccines available for COVID, that gives us opportunity to expand the access to these services very quickly. So if you're ready, I think we just proceed. For the screening testing, we've actually chosen 5 pilot sites, while for vaccine, 50 sites have been chosen to scale up vaccination for people who require them to state. And this program and this project is supported by CDC IGN. They provided a lot of technical support and resources to make sure that this is possible in all the sites that we are working in. For the screening and testing sites, basically the sites are River State University Teaching Hospital, UPTH, Zonal Hospital Bori, Zonal Hospital Ahoda, and Zonal Hospital Bori. And these are really high volume sites, and they all have capacity to be able to test and screen very quickly for TB, HIV, and even COVID. And so you can get results within a very short period of time. In fact, for HIV and COVID, you can know your status within 15 minutes at these sites. For virtually for all of them, we have GeneXpert sites running at these sites, and they will also be able to give you results in the same day to tell you what is the status of the patient who is presumed to have TB. So are there benefits to this program? Yes. Like I said earlier, it actually helps us expand the patient-centered service delivery, so patients have access to care. Patient comes to hospital, the patient can actually get opportunity to know his status for TB, HIV, which are indeed common diseases within our environment. Prevalence for these diseases are pretty high, and every facility must have opportunity to avail patients who visit these sites these services so that they can adequately tailor their care to meet their needs. So because we're doing this very quickly and you can have results quickly, outcome is better, diagnosis is quicker, the system is strengthened, the resilience and recovery is better, and we do this without stigma, and while we're creating demand for the vaccines. So the services have been we've strengthened the logistics to ensure that they're sustainable and efficient in the pilot sites. And it has one other great advantage, which is the fact that if breaking it in simpler forms, if a patient comes to hospital, for instance, patient came with a sprain, is not unduly exposed to other infectious diseases like COVID. So in so saying, in technical terms, we are reducing nosocomial infections in the hospitals, which are infectious diseases that the patient may get while in hospital, different from the reason why she is being managed in the facility. So this also reduces nosocomial infection spread within the hospital and also protects the healthcare workers, so preserving our human resources for health. In doing this, we take into consideration certain issues that may arise in the course of it. So we did a situational analysis, we're strengthening infrastructure, co-creating ownership between the facilities, the state, the partners. So it is a win-win situation for everybody. We're managing most of the challenges, improving on the technical capacity to ensure that we can get the service efficiently running at most of the sites. So of course, like I said, not to say that any system is perfect or any protocol is perfect. We are also looking at all the concerns that may arise from it. Like I said, we're trying to co-create ownership. We have regular meetings to strengthen capacity, making the support very sustainable. We have orientation campaigns to reduce vaccine hesitancy. The protocols are being developed. We're managing time to ensure that patients do not spend time unduly in the facility, and also ensuring that the data is transmitted in real time so that it helps in the management of the patient who has come to hospital. So the question is, how do the facilities go about this? Nothing really out of ordinary, except, of course, you recall that when a patient comes to a facility, the facility has a duty to ensure that IPC standards are optimal. And that includes the fact that the face masks are enforced and wash stations are ready, hand sanitizers are also okay. You have already been prepared for the integrated services. You have a screening tool, and of course you cross-check to ensure that the patient flow is adequate. What is basically the patient flow is the fact that all the patients who come go through a screening, and if they meet the definition for any of these three diseases, they are tested. After the testing, the result is transmitted in real time, so with shared confidentiality to the managing physician, so that he is aware, even as the patient approaches the clinic, on what the patient may need to feel better and get back to society as quickly as possible. So in a nutshell, what we want to achieve is that we administer a screening tool and we screen for TB, COVID, HIV in quick succession. In very few minutes, all this is done and the patient is assessing all the services that has brought the patient to hospital. So how do we really achieve this? You might want to ask. The first is that most of these diseases have a case definition profile. So the screening tool actually screens for COVID to see whether you met the case definition profile, fever, cough, respiratory symptoms. If you do, the patient is screened in for testing. If it tests positive, it's positive for COVID, it's protected with a respirator, it continues its sojourn at the hospital. For HIV, of course, they ask for risk stratification. In other words, they ask when you did your HIV test last, multiple concurrent sexual partnership, use of condoms. If the patient also meets the profile, the patient is screened. Depending on the status, the patient also proceeds to assess the services in the clinic. The same for TB. Patient has fever, sweating, night sweat, weight loss. Patient meets the profile, case definition for presumptive TB. Sputum is taken for GeneXpert, and you can get result in the same day. And of course, within this period, there are staffs available to also look at the vaccination status of the patient to see if it's up to date and offer the patient vaccination services. So basically, it's a one-stop screening opportunity covered by IPC, no stigma, in the protocol, and allows the patient to access all the services he needs in the hospital safely in such a way that it doesn't pose danger to anybody, and at the same time he gets the care that he or she needs. So what is the protocol in case somebody tests positive or negative? Like I said, basically the same things that we do all the time in the facility. For COVID, for instance, if patient tests negative, he proceeds on enjoying all the services that are available in the hospital. If the patient tests positive, he's given a respirator that sanitizes his hand, and he has little capacity to transmit the virus while that patient is in hospital. And so he can also access the services, see the doctor, and can continue on his way around the hospital and the services that he needs. For TB, it's the same. The patient tests negative, proceeds to access other services, tests positive, sputum is taken for GeneXpert. Of course, all patients are wearing a mask. And for HIV, it's the same. Patient tests negative, continue to access services. Patient tests positive, is quickly enrolled, and the drugs are very effective within a short period of time. Patient can also have viral load undetectable and enjoys normal life. So it's a win-win situation for both the patient, the facility, and the public health space to ensure that our patients are doing better and accessing all the care that they need in one swoop, with a single switch. You can actually achieve all this for one patient rather than have the patient move from one end to another end, checking up. So all this is happening right in one state. And the kind of question most times the facilities and healthcare worker ask is, what if the patient is COVID positive? What is the protocol for management? The protocol of management has not changed. It's basically the same. If the patient is an accidental find, in which case, for instance, patient has come to hospital because of a sprain, and you find that the patient meets the case definition or is he requested for testing and is asymptomatic, the management is that the patient assesses all the care he needs for comorbidities and proceeds on self-isolation at home. And of course, the rapid response teams will follow up to show that the patient is doing great. If the patient has is symptomatic, in which case it is between moderate and a severe form of COVID. It means that the doctor has to determine whether the patient needs facility care. If he needs facility care, the patient is transported very quickly to the isolation facility. For instance, in Arroyo City, there's an isolation facility by the corner. So he continues to enjoy the services, even for comorbidities that he has while within the hospital. So, like I said, it's a win-win for all the patients who come to hospital in a single switch. They can get all the values for the healthcare services. Basically, for the emphasis, when once a patient tests positive for COVID with heredity, that the facility, that patient is treated as COVID positive. If he doesn't have symptoms, they are basically asymptomatic and an accidental find. Patient continues to access the services wearing a respirator and goes on. Is placed on a home-based care where he stays on home isolation until after 10 days of being asymptomatic, patient exits surveillance and reunited into society very safely. That way, the transmission of the virus is totally interrupted within that cluster. For moderate to severe cases, just like I said to you, the doctor will take a decision based on the findings he's seen. Patient has respiratory distress, SpO2 is less than 90, patient needs a lot of hospital care. Immediately, the patient is transferred to holding facility, which is also by the corner, and within there, patient is cared until it becomes asymptomatic and is discharged home. So, in a nutshell, what we're trying to say is that for every patient that comes to hospital, it activates the button of either screening the patient in for triple disease screening or screening patient out for triple disease screening because it doesn't meet the case definition profile. And for all the patients entirely, they all enjoy opportunity to get their vaccine status up to date so that we can achieve herd immunity. So basically, we cut a long story short, we're screening for TB, HIV, COVID, and we're making sure we're doing this no stigma protocol. Data is well captured, transmitted in real time, enable us to make decisions on informatics and how we proceed in strengthening the system for it. So this is what it is. In a nutshell, the program has been launched in Rivers State University Teaching Hospital, and it's getting us strong and better by the day. And I urge you all to use the opportunity to be part of it, strengthen it. Let's work with it to ensure that our systems are better. Thank you.